GI psychologist at the University of Michigan. Today, I'll be presenting Multidisciplinary GI Care, a brief review of brain-gut therapy. As we get started, I'd like to review what is psychogastroenterology. It happens in the context of providing patients with a collaborative, integrative team to address their GI symptoms. In this team, it can provide and can include a variety of specialists that can include the primary care physician, a general mental health provider, a registered dietitian, gastroenterologist, psychiatrist, geneticist, or a GI psychologist. We each offer patients opportunities to address aspects of their health that, when correctly addressed, can improve their overall physical symptoms. The interventions that we utilize with patients are from an evidence-based psychological perspective that really targets the digestive condition that the patient presents with. Appropriate referrals for working with a GI psychologist include many patients that have disorders of gut-brain interaction or functional bowel disorder. And this can include IBS, functional dyspepsia, functional heartburn or PPI non-responders, globus, and functional dysphagia. So we really can apply our psychogastroenterology brain-gut interventions to patients with both upper and lower GI conditions. Our interventions are also effective for patients that have more organic diseases, such as Crohn's disease, ulcerative colitis, celiac disease, GERD, and chronic pancreatitis. And with many patients that have inflammatory bowel disease, even if their disease is in remission, working with a GI psychologist to help with some of those functional overlap symptoms can be very beneficial. It's also important to cover the inappropriate referrals, because there really is a difference between working with a GI psychologist as well as working with a general mental health provider. So a patient that has more severe psychiatric conditions, such as untreated major depressive disorder, generalized anxiety disorder with ongoing panic attacks, active eating disorders, any patients with psychotic symptoms, suicidal ideations, a recent suicidal gesture, these patients really should be prioritized to more comprehensive mental health services. What we've found is that many of our GI behavioral health interventions are not effective when a patient's mood is unstable. Therefore, we want to optimize getting them treatment for their general mental health condition first. We know that patients that have disorders of gut-brain interaction, such as irritable bowel syndrome, really the diagnosis is complex, and oftentimes even something that's happened early in life can contribute to symptoms and or diagnoses later in life. So when we look at some of the factors that can contribute to this complex diagnosis, it includes early life stress, patients that have experienced trauma, abuse, or neglect. Some patients may experience these while others may not. So we're not generalizing, saying that all of these patients are going to have early life traumas, but it's certainly something to continue to consider, as well as screen for in your clinic. Symptom hypervigilance, as well as visceral hypersensitivity, can also contribute to the complexity of these diagnoses. So these are patients that have benign or unremarkable medical workups, but the symptom hypervigilance and the visceral hypersensitivity can really drive that symptom experience and frustration with their diagnosis. Having poor coping strategies or poor lifestyle experiences, such as poor sleep, are also factors. And therefore, it oftentimes takes different specialists to address whatever factor might be contributing to the patient's diagnosis. When it comes to that diagnosis, especially in patients that have irritable bowel syndrome, having a confident diagnosis, so you as the medical provider really confidently and definitively providing that patient with the diagnosis is really important, because it provides reassurance that their diagnosis is correct and ensures that no additional workup is necessary. A lot of times, especially in our tertiary care center at the University of Michigan, patients are coming to our gastroenterologists for second, third, fourth, fifth opinions. And unfortunately, while the patient is still suffering, the diagnosis really doesn't change a lot, but how you deliver it and instilling confidence that we have a treatment plan that can offer the patient relief really makes a big difference. So that confident diagnosis can create hope for these patients. And when the patients have hope, they oftentimes have more motivation to pursue a multidisciplinary treatment plan. So as you think about introducing the concept of a brain-gut intervention for a patient and making that referral to a GI mental health provider, here's some of the review of the literature on types of techniques that I utilize in my clinic. So the most implemented in clinical practice is cognitive behavioral therapy that focuses on the GI symptoms. So we call this GI CBT. And some of the primary techniques really address modifications of arousal, helping the patient cognitively reframe the ways that they're thinking. So oftentimes in these patients, we see them catastrophizing about their symptoms. If I don't get to use the bathroom right before I leave for work, I could have an accident in my car, and then I'm going to be late for work and lose my job. And so we can see how a patient's thoughts around their GI condition can really snowball and catastrophize. The other most implemented intervention in my clinical practice and in most GI psychologist practices is gut-directed hypnotherapy. And this also gets at modifications of arousal by providing patients with very specific suggestions to improve the brain-gut dysregulation that's happening with their GI symptoms. Other emerging areas in terms of the class of behavioral therapy that we're utilizing with our patients are mindfulness-based stress reduction techniques, as well as psychodynamic interventions. So as we can see, and as we can describe with patients, that certainly while the brain is involved in their symptoms, they're not making their symptoms up when they're working or being referred to a GI psychologist. I think that's another very important point to make as we think about incorporating these brain-gut psychotherapies into treatment, is helping the patient to know that we believe them, we know their symptoms are very real. And as we can see, many of these processes that are happening through the brain and the body and the brain-gut connection are really being addressed utilizing these strategies that have been proven very effective. And so I think helping patients to understand that there is a strong connection between your brain and gut, but not that you're unremarkable, or the fact that we haven't identified anything from a medical perspective indicating organic disease. We can really utilize these behavioral therapies to address that brain-gut access and brain-gut dysregulation. So briefly in these next couple of slides, I'm going to cover a little bit more information about cognitive behavioral therapy, hypnosis, and some of our newer wave therapies. So this was a very helpful systematic review and meta-analysis by Black and colleagues, which really indicated that our interventions from a cognitive behavioral perspective, as well as our gut-directed hypnosis, they have the largest evidence base, and they're very effective. And that's another important point to make with our patients when we're introducing these types of kind of multidisciplinary approaches, because a lot of times patients haven't heard of them, or they're skeptical. And so being able to help patients understand there's a very large body of research that supports the use of these interventions, even especially for patients that have been refractory to medical treatment, can help them with their buy-in. So after completion of therapy in group CBT, so we find that these therapies can even be delivered via group. Again, it was more effective than just education or support routine care. And especially relevant in the time of the pandemic, where many mental health providers have shifted their clinical practice to virtual sessions, the literature supports that these interventions are just as effective when delivered via phone or internet. And so this has been very helpful. Again, even being able to deliver these treatments via virtual care, this has improved, especially in my clinical practice, where patients sometimes are driving several hours to get to our clinic. The opportunity for patients to complete their treatment, to not have to deal with parking, and to really learn the interventions from the comfort of their own home. So I think it's very important to highlight for our patients that the research supports us continuing to offer these services virtually. Medical hypnotherapy is always something that patients, they're either a little skeptical of, or they are all for this treatment and really interested in it. So there's no clucking like a chicken when a bell goes off. These are medical interventions that have been thoroughly studied over the years, with over 35 studies looking at the use of hypnosis for patients with both disorders of gut-brain interaction, but also inflammatory bowel disease. We've also applied these strategies to esophageal conditions with good success. And so when patients are open to utilizing this intervention, where we target suggestions about the calming and soothing of the digestive tract over the course of about 5 to 7 sessions, the patient will typically experience quite remarkable improvements with a number needed to treat of 2. And so patients typically will learn the strategy with the provider in session, and then be given audio recordings that they'll utilize in between their sessions. So really building the skill of self-hypnosis over time as well. Now, mindfulness and relaxation are both important, especially when it comes to helping to reduce physiological arousal in patients that have these disorders and GI diagnoses, but they're not the same. So mindfulness-based stress reduction is, again, another evidence-based intervention where patients learn skills to manage discomfort by oftentimes sitting with that discomfort. And relaxation training, though, can modify their physiological arousal, and we can give them very specific tools that they can utilize, such as diaphragmatic breathing. And I've actually included an example of how to teach diaphragmatic breathing to patients with gastrointestinal conditions. And patients can learn this in the clinic room, they can practice at home. And my suggestion is always to help the patient recognize that this is a tool and strategy. It can be helpful to practice even when not in distress or experiencing symptoms, because it's going to activate the body's relaxation response. And it can be helpful for patients whether they're having diarrhea, an urgency, or constipation. So a very beneficial strategy. Finally, I'll wrap up with a couple words here on digital therapeutics and mobile applications. These are self-guided, again, evidence-based programs where they're really taking the strategies that we would utilize in session with patients, so in person or virtually, and giving patients the control and the ability to utilize them on a mobile app. And so oftentimes the interventions will include tracking symptoms, bowel habits, mood, diet, and anything else really that would be of relevance. And through the app, the patients are receiving psychoeducation about their diagnosis, as well as therapeutic strategies that come from many of the techniques that they would learn in person. So I think these digital therapeutics really offer improvements to access issues, given that really getting into a GI psychologist can still be difficult. And so I do think that this allows for some access improvements. And here are a couple examples of some of the digital therapeutics that are out there right now. Nerva is an app that, again, is self-guided and provides patients with gut-directed hypnotherapy for their GI condition. Zemity includes also many aspects of GI cognitive behavioral therapy, and also has some relaxation and hypnosis modules a part of the program. And then Mahana Therapeutics is a different strategy that is actually an FDA cleared digital therapeutic that will be something that providers can prescribe for their patients. So it's a prescribed cognitive behavioral therapy therapeutic. And so as we can see, kind of the go-to-market strategies for some of these products is different, and it's important for gastroenterologists to be aware of them. So my take-home points are that patients and providers can certainly benefit from an integrative GI care model that includes brain-to-gut psychotherapies and psychogastroenterology in general. Understanding appropriate referrals can help to optimize a patient's ability to receive the right care and create realistic expectations. So we want to make sure that the patients that really need more comprehensive mental health treatment are going to general mental health providers, and the patients that can really benefit from tools and strategies to improve their GI symptoms would be optimized and over to the GI psychology colleague. Virtual care is effective. It improves access and treatment completion. And finally, as I've said, behavioral therapy is something that we still have some access barriers around, and therefore digital therapeutics, I think, will provide some much needed solutions for the right types of patients. Thank you so much for the opportunity to discuss behavioral therapy with you today. And I look forward to connecting with you on social media.